This conference will now be recorded.
Hello, everyone. Welcome and thank you for joining us for this edition of the ACRM Pandemic Webinar Series, produced by ACRM, the American Congress for Rehabilitation Medicine, and the ACRM Technology Networking Group to help bring needed information to rehabilitation researchers and providers during the pandemic. This webinar is produced in collaboration with ACRM's Spinal Cord Injury Interdisciplinary Special Interest Group, and I'd like to thank Dr. Jean Zanka and Dr. Denise Fife for helping to coordinate this webinar. My name is John Morris, and I have the honor of moderating this webinar. I'm in immediate past co-chair of ACRM's Technology Networking Group and currently still serve on its executive committee. And I'm a research scientist at Shepherd Center in Atlanta. Today's topic is caring for the future, building partnerships between home health workers and rehabilitation professionals in the age of COVID-19. Before we get started with the presentation, I do want to advise that this meeting is being recorded. We ask all attendees to keep your phones and your microphones muted and keep your cameras turned off throughout the presentation. We expect to have about 20 minutes available for discussion at the end of the webinar. So if you have questions, please type them in the chat feature in GoToMeeting, and we will address as many of those as we can during the later part of the hour. And now, it is my pleasure to introduce our guest speaker, Robert Espinoza, MPA. Robert Espinoza is a nationally recognized expert in aging, caregiving, and long-term care workforce issues. He is Vice President of Policy at PHI, New York-based PHI, where he directs a national policy advocacy and research program on the direct care workforce. In 2015, he was appointed by the Centers for Medicare and Medicaid Services to its advisory panel on outreach and education, as well as by the National Academies of Sciences, Engineering, and Medicine to its Forum on Aging, Disability, and Independence. Robert serves on the board of directors for the American Society on Aging and the National Academy of Social Insurance. Robert, we look forward to your talk, and now we'll turn the presentation over to you. Welcome, Robert.
Thank you, John, and thank you to ACRM for inviting me to speak today and for including this really important topic of the direct care workforce of home health workers and the role that rehab professionals in the age of COVID-19 can have in strengthening and stabilizing this workforce. I'm excited to speak today, and I'm going to be guiding us through a variety of topics that will hopefully give everyone a better sense of who this workforce is, some of the key challenges facing these workers, how the COVID-19 has changed and in many ways amplified the challenges facing direct care workers, and what rehab professionals can do to engage and work closely with direct care workers and also stabilize this workforce in the years ahead. Just to give you a little bit of a sense of who I am the Vice President of Policy at PHI, formerly the Paraprofessional Healthcare Institute. We are a national organization that's focused on strengthening the direct care workforce, and I'll give a definition in a few minutes. Our approach is through three dimensions. First, we study and analyze the direct care workforce. We produce data and reports and a wide range of analyses to help providers and advocates and government officials better understand who these workers are and also what the future looks like for this landscape. The second dimension is that we work closely with providers and a whole range of actors, institutional actors around the country to develop a wide range of workforce interventions. And we offer a variety of consulting service lines as well, including training, developing advanced roles, supporting them through recruitment and retention challenges, and so on. And then, of course, because we're interested in systemic change, we advocate for policy reforms at the federal, state, and local level. We also educate the public on the variety of challenges facing these workers. We often say that we have a 360-degree perspective on this workforce and this sector because our wisdom and our insights come from a variety of places, including our original research, which gives us in the field objective facts and trends, what we call a provider learning lab from what we're doing in the field, working all around the country, rural and urban areas and everything in between. And in New York City, where we've been based for almost 30 years, we have various partnerships where we learn from thousands of workers and consumers in one of the country's kind of most complex long-term care systems. So a lot of the analysis that I'll be bringing is from the wide range of work that we do. The philosophy of our work is that we believe that caring, committed relationships between direct care workers and their clients are at the heart of quality care. And those relationships work best when direct care workers receive high quality training, living wages, and respect for the central role they play. And I'll be talking about what specifically that looks like from both a policy angle and also a practice angle. So what is the direct care workforce? But just a short definition, they are the paid frontline of support for older adults and people with disabilities. They work in a variety of settings. They work in private homes, in nursing homes, and in a wide array of residential care settings, in assisted living settings. And I know that for this presentation, we'll probably be looking more closely at the role that they play in private homes and also the relationship between workers and rehab professionals, but it's important for us kind of to situate what the broader workforce does. We calculate that there are about 4.5 million home care workers and nursing assistants around the country. It is actually the largest growing job occupation in the country. Unfortunately, as I'll talk about in a few minutes, this is a workforce that also deals with profound challenges and high turnover rates. And so we estimate that between 2018 and 2028, the long-term care sector will need to fill about 8.2 million job openings in direct care. These are jobs that are being created because of growing demand, but it's actually a lot of jobs because workers are leaving the workforce or they're leaving the sector for other sectors like retail or fast food. It's one of the challenges that many employers have in this space, consumers as well, which is how do you recruit and retain workers, recognizing that there are so many job openings happening, especially in the next 10 years. Just to give a little bit more definition on the direct care workforce and also on estimates. So direct care workers fit across a variety of job occupations. Some of these job occupations have been defined by the federal government in terms of occupation codes, and it's where we draw our names. Home care workers include both personal care aides and home health aides who provide daily support to older adults and people with disabilities. The primary difference between personal care aides and home health aides is that home health aides also offer clinical support. So in that sense, they are often much more regulated than personal care aides, and they undergo kind of a heavier training requirement. They undergo more training requirements. We estimate there are about 2.3 million as of 2018. Another category are nursing assistants who work in nursing homes, and they do everything home health aides do, but they do it obviously within the nursing home setting. There are also direct care workers who work in residential care settings, assisted living communities, continuing care retirement, residential care homes for people with intellectual and developmental disabilities and group homes, and then direct care workers in other settings, from hospitals to employment services to vocab rehab services, among others. And you can see the numbers in this slide, about 580,000 nursing assistants, about 700,000 working in residential care settings, and then about 900,000 in other settings. I want to highlight two other segments of this workforce. Also, many consumers hire their own workers through consumer direction programs or publicly funded programs, right? And we could refer to this workforce as independent providers. We estimate roughly there are about 1 million as of 2016. And then there are also direct support professionals. And these are professionals that support people with physical, intellectual, and developmental disabilities, often through programs that are specifically meant to support and fund direct support professionals. And oftentimes, direct support professionals are also working closely with consumers to maximize their employment, their community engagement, to really partner with them to understand sort of how do you bring that person-centered, person-directed lens to their supports. And we estimate that I believe that there are 1.3 million direct support professionals in this country. However, one of the challenges with this segment of the workforce that I want to highlight is that there is no federal occupation code for direct support professionals, and that's a major problem. It prevents us from knowing how many workers there are, in truth. This estimate is actually drawn from the direct support professional field, the National Association of Direct Support Professionals mostly, and we assume that many of them are subsumed in the $2.3 million figure, but unfortunately, without a federal occupation code, it's difficult for us to know what that precise number is. But you can see already the wide variety of occupations and segments within a pretty strong workforce. Who are these workers? About 86% are women, so this is largely a female workforce. About 59% are people of color. We're looking closely, by the way, here. This is looking at direct care workers, not necessarily a segment of the workforce. About 1 in 4 direct care workers is an immigrant. The median age for workers is about 41, although we recently did a study that showed that about 1 in 4 direct care workers is aged 55 and older. So already we're seeing the ways in which the aging of this country is also shaping this workforce, and that we're seeing kind of an increasingly older workforce. We estimate that there are about 1 million immigrants working in the direct care workforce. And we highlight that, of course, because we're living in a moment in which anti-immigrant sentiment is on the rise, and a variety of measures are being implemented that would make it more difficult for immigrants to enter, to live, and to work in this country. And so we should think about the implications in terms of what it would mean both for workers, but also for people who rely on these services. Why are there so many jobs? Why will we see so many job openings in direct care in the next 10 years? One major reason, and I'll talk about it in a few minutes, is because the jobs are so often poor in quality that they drive workers out of these roles. But another reason is that we're actually just seeing growing demand. More and more jobs are being created, and this is for 4 major reasons. The first is that we're seeing more older people. Between 2015 and 2050, the number of people age 65 and over will more than double from 47 million to about 88 million people. And I know that rehab professionals work with people across the lifespan, but one of the reasons that I think it's important to mention this is that the growth in older people also puts pressure on the overarching system, right? And so it puts pressure on the money going into the system and the workforce, the ability for us to identify enough workers and receive enough hours of support. I mean, that's a major trend igniting demand. The second is that people are living longer, and oftentimes with older age comes increased functional limitations and daily support needs. We often talk here about also how we're seeing an increasingly complex population in terms of complex care needs. We're seeing higher rates of Alzheimer's and other dementias, or higher rates of diabetes and cardiovascular disease. And who knows what kinds of long-term, short-term and long-term complications COVID-19 will create. But the trend here is that as the population of people needing support becomes more complex, the kinds of skills and needs and pressures that workers need to be able to address will also become more complex, and we should think about that as we transform these jobs. A third dimension is that by and far most people prefer to age in their homes and communities versus a residential setting, and this is putting incredible demand specifically on home care workers, which is the part of the workforce that's the largest growing job occupation in the country. For now, unfortunately, because as a country, we haven't figured out how to properly fund home and community-based services. Many people who require 24-hour skilled care still receive that care in nursing homes. And so I think as we look forward, we're going to have to see sort of the impact that a preference for home and community-based services is having on this sector. A final trend is that we're just seeing new norms, new family norms. It is more likely that people are aging without children. People are aging single. I think the word is singletons. We're seeing it's more common for children to leave the home, leave their cities and states, and that kind of decreases the supply of family caregivers, and it puts more pressure on paid caregivers, on the direct care workforce and other kinds of supports. I think that we're often asked, how does the culture of long-term care in the U.S. differ from the rest of the world? And this is probably an area where we would see stark differences in that many parts of the world. It's still very common for family caregivers or neighbors and community members to support people as they need support, this type of level of support. But that's a trend that's shaping the US for sure. The direct care workforce, as valuable as they are, as critical as they are to the daily lives of older adults and people with disabilities across the spectrum, and people who need rehab support, they still face a range of challenges. And I'm going to guide us through a variety of these key challenges. Chief among them is that direct care just doesn't pay enough. We see that wages are often too low, and this drives many workers into poverty. Our latest data shows that the median hourly age for home care workers is about $12.27. And that's a wage that, by the way, has not increased in the last 10 years once you adjust it for inflation. So this is a wage that has stayed exactly the same in the last 10 years, despite the cost of living, of course, has increased. What we know is that many workers are often relegated to part-time work or to irregular schedules, and 30% of workers work part-time. Because of the low wages and the part-time work, the median annual income for direct care workers is $20,000 a year, and for home care workers, it's much smaller. So imagine if you were a low-wage worker and you earned $12 an hour, $20,000 a year, and you had children, et cetera. How would you allocate that money across a wide range of expenses, from rent to food to entertainment to health and nutrition to pay for credit card debt? I mean, the wide array of costs that a lot of us pay in our daily lives, it goes very quickly, and which is why we often see that 44% of direct care, of home care workers are living in or near poverty, and that's a major problem for this sector. Another area is that we find that the training for direct care workers is often insufficient, and there isn't enough career advancement opportunities. There aren't enough career advancement opportunities for workers either. One thing that we see is that the training standards, especially for personal care aides and for direct support professionals, they just aren't strong enough. Home health aides, as I'll talk about in a few minutes, and nursing assistants are required by the federal government to undergo about 75 hours of training, and in some states it's more. Unfortunately, for personal care aides, there is no federal requirement, and no state goes past 40 hours, and many states it's far fewer than that. So this means that, you know, if you're hiring and working with a personal care aide or direct support professional, and that requires a specific type of training, it's difficult to know whether they have undergone kind of a legally required training program that gives them, imparts with them all the skills, all the knowledge, and all the competence they need. We're also seeing, you know, in general, that most programs lack training in specialty topics. I mentioned the rise in dementia, the issues of cardiovascular disease, diabetes, COVID-19 training, and so on, or training for special populations. We're seeing an increase in attention around LGBT competence, and yet it's unclear whether or not workers have been trained on those issues to deal with those populations. Our experience working in the field shows that oftentimes programs, training programs, are didactic in nature and that don't always account for adult learners or people with different learning styles. In fact, that makes it really difficult for workers who need different methods and more engaging methods to really achieve the skills and the knowledge to do their jobs. And that's a major problem with the quality of training programs. Finally, we see few advanced roles where workers could play kind of a more meaningful role as part of the care team, the physicians, the social workers, the family caregivers, the rehab professionals, right? The wide constellation of people who often impact a person's support system. There are a few roles that would allow workers to be properly integrated into those care teams, but also roles that allow them to advance in their careers and probably take on a more expansive role or you know, improve their compensation and contribute to the kinds of outcomes that so many providers and government officials are interested in, like reducing cost, for example, or emergency department visits is another example. This is a slide that shows the state-by-state patchwork of training standards for direct care workers. What you see here is that home health aides are federally required, and so are nursing assistants, to undergo at least 75 hours of training. But in many states and the District of Columbia, they're required more than that. 17 states for home health aides and 30 states for nursing assistants. Unfortunately, for personal care aides, nursing assistant, independent providers, and direct support professionals, there is no federal requirement. And only 14 states have consistent training requirements for all agency employed personal care aides. This means that if you're an individual and you've hired a personal care aide, especially outside of an agency, the likelihood that they've received any training at all is probably minimal, although it will depend, of course, on person by person. You might be hearing a sound in the background. I apologize. That's in the street noise. Another challenge that we see in the sector is that many employers are increasingly struggling to recruit and retain direct care workers, especially for the last few years in an economy where those workers had other options. There is no reliable data at the state level on direct care workers, and that's a major problem. We take our data from federal data sets, but most states don't have data collection systems that can tell you how many part-time or full-time direct care workers there are, or how vacancy or turnover rates or compensation levels, et cetera. However, so there's no kind of reliable estimate on the turnover rate within this sector, especially by states. However, most of the research that we've seen, which are often smaller samples or focused on specific segments of this workforce, show that the turnover hovers around 60%. And often the primary reasons when you ask workers for leaving these jobs are that the wages are too low or poor supervision. But 60% turnover rate is it's a high turnover rate, and it's also expensive. Some research has calculated that it costs an employer about $2,500 per turnover. So it's expensive over time on the employer. It's expensive on the consumer who loses that continuity of care when a new worker shows up. And might lose that continuity of care when their worker shows up. And it's expensive on the system, which is paying for this, right? What we have found is that in a time where workers have more jobs and we're seeing a good economy of at least a number of jobs, although the quality of jobs, of course, have not been strong, it makes it more difficult for long-term care employers to hire workers. So in many states, we were seeing that long-term care employers were struggling with retail and fast food. They were competing with these industries for the same candidates, and that makes it more difficult to recruit and retain workers. A few years ago, we looked at the direct care workforce landscape in the sector in Minnesota, and we looked specifically at what we call the care gap. It's an insightful measure, though it's imperfect. It looks specifically at the difference between people age 65 and older and the typical demographic of direct care workers, which are working age women aged 20 to 64. What you can see in this slide is that care gap begins to grow in non-rural parts of Minnesota, somewhere in the 2035, 2033, but that care gap starts to grow in rural Minnesota in 2021, 22, and it explodes in the years ahead. And so what that shows us is that if it's difficult to recruit and retain workers in non-rural settings around this country, it's even that much more difficult in rural parts of this country. And I think hopefully we'll get to better data over time as states develop better measures where you can get a sense of what that looks like. I think, so much of the philosophy that we ascribe to is about person-centered approaches. How do we honor the needs, the preferences, the aspirations of individuals? Unfortunately, it hasn't gained enough traction in the long-term care system across the variety of actors with which we work. And for us, it has two dimensions. One is that we often see that direct care workers, they're not always trained in person-centered approaches. And this can create obviously challenges if they're not honoring who that person is in terms of their needs and their aspirations. And likewise, many employers, whether you're an agency or individuals, aren't honoring the person-centered needs of the worker. And so we think about the importance of creating both a person-centered approach to consumers, but also a person-centered approach to workers to think about what does the worker need as well, because the quality of care that's delivered is so reliant on the quality of jobs as well. The other piece that we should remember is that we're in a country that is already diverse in a number of ways and is becoming increasingly more diverse in the decades ahead. I think that sometime between 2053, this country will be majority people of color, and in many states sooner than that. We also see that it's not just more diverse, but that there are persistent disparities in the workforce, in the long-term care system, and at society at large. And we're in this really important historical moment where we're thinking about the impact that systemic racism in particular has had on the health and on the life outcomes of so many people, whether it's through police brutality or whether it's through COVID-19 and nursing homes and so on. For us, it means looking at the ways in which we should adopt a cultural and linguistic competence approach to everything that we do, from the workforce solutions that are at a minimum race explicit, that we're looking at how racial inequality is shaping the quality of these workforce interventions, through a wide range of kind of cultural and linguistic competence approaches that really challenge this mindset that a universal approach will work equally with everyone, which vast research shows it doesn't. There are many ways in which programs that work well with a dominant group don't work well with the more marginalized groups. And so how do we make sure that our services are in the language of the people that we're supporting, but are also relate to them culturally? I mentioned earlier that we're also in a time in which data on this workforce is just not as strong as it should be. The three areas that are often understudied that we argue for in terms of improving are volume, stability, and compensation. Volume would tell you how many full-time and part-time workers there are. Stability would tell us vacancy rates, turnover. Compensation would tell us how much they're making, poverty rates, and so on. And those three would, at a minimum, provide a really strong picture of what a workforce is dealing with. When COVID-19 emerged, one of the key challenges we had, and one of the primary questions I received was, if COVID-19 is hitting some parts of our state more aggressively, might we, look to other parts of the state to identify workers? The challenge in our system is that we don't have enough data at the state level to tell us at any point, were there more workers in rural Minnesota than in New York City, where the epicenter of the virus really took hold, right? And so I think as we think about solutions, we should think about that data. I mentioned there's no occupational code for direct support professionals, and as I said earlier, there's data on where workforce needs are the greatest. All of this is under an umbrella that this system is vastly underfunded. It's chronically underfunded. For the consumer, it's difficult to predict how much money you will need to support long-term care, which also makes kind of private long-term care insurance programs a little bit untenable. How much should you save? How much should you take out of your pocket? I mean, you may not need any long-term care. You may need, say, $5,000 to $10,000, or you may need $1 million worth of long-term care, right? It's difficult to know how much you will need in any of our lives, and many people end up exhausting their savings and spending down their assets. Medicaid, which is the primary payer for long-term care, is really only for poor and low-income people. And the restrictions are growing. In many states, Medicaid is highly politicized, and oftentimes budgets are always being threatened. And if state budgets are strapped and increasingly strained, there's even less money to improve jobs in this sector. So what many providers, many employers of direct care workers will say is that they simply don't receive reimbursement rates from the government that would adequately cover both the cost of delivering services, but also improve jobs with higher wages and so on. And so it creates just an overarching systemic problem. COVID-19 in many ways brought to light and really exacerbated the challenges facing the direct care workforce. We saw right away in the beginning of March that these workers were essential to the response. And yet we knew, just having studied and worked with the sector for so many decades, that all of the problems we had been highlighting for decades, of course, were going to become that much more pronounced, and it was going to make it difficult to keep people safe, whether we're talking about consumers or workers. Some of the major challenges we saw during this time, one is that initially, direct care workers in most states, if not all states, they were deemed essential workers, and that they were asked to go to work, they were allowed to go to work, and they were seen as essential really to the lives of older adults and people with disabilities who needed them. But as I'll point out in a second, they were also undervalued. I mean, we didn't see them, for example, in the mainstream telethons or in fundraisers that were going towards essential workers, which seemed to focus more on physicians, on emergency care clinics, on nurses, even on grocery store workers, all of whom, of course, merited that level of support. But it was unfortunate for us that we saw direct care workers absent from that mainstream dialogue. We saw routinely that workers and employers from the very beginning and to this day did not have enough access to PPE, to supplies, or to any general resources, thermometers, and so on. And workers, of course, for years, were inadequately compensated and often didn't have access to paid leave or to childcare. In states where schools were closing, actually in most states where schools closed, this made it difficult, almost impossible if you were a worker, to figure out what do I do with my children, right? When the schools are closed and I'm expected to go to work. Also, they were forced to make an impossible choice, which is go to work and not know whether or not I'll be protected and risk getting infected, then infecting my clients and my family members, or staying home and entering financial ruin, right? Collapsing financially. And so it created an even greater workforce shortage that we're still struggling to figure out what to do with. And we're starting to see some early data on the number of deaths of both residents and workers in nursing homes, although there's far less data for a variety of reasons on home care workers. So the workforce shortage that many of us had been talking about for years, and if not for decades in the making, really has become exacerbated in this time. We also need to bring more workers into this sector, yet most training is in person, and that's for a variety of good reasons, and that it's evaluated and it's been shown to be the best method to train workers. Also, there are a number of requirements that require hands-on demonstrations that a virtual approach may not achieve. That creates a challenge in this point, in that we don't have the proper training infrastructure to develop that hybrid approach of in-person and virtual approaches. And that's a problem as we think about both bringing more workers into this sector and also training them on COVID-19 realities as COVID-19 evolves and our understanding evolves. We released a report a month ago showing how fractured and scattered the long-term care system is, and that makes it hard to respond in a uniform way and quickly to this pandemic. And in general, we've seen that most state policy responses or the federal relief bills have not explicitly dedicated resources to this workforce. A few states improved pay for workers temporarily, or hazard pay, but it was, I think, 3 states that we've seen do that for the most part. So given all this, what are some of the ways in which rehab professionals can improve job quality? I think it's important for us to keep in mind, and I'll reiterate some of these points, that we're seeing a growing and changing demographics. And so as rehab professionals, acknowledging that workers are reflecting that changing demographics, and what are some of their specific needs, what's the kind of competence I can develop to work with a population that's largely women, people of color, increasingly immigrants, LGBT, and so on. It's clear that the future of healthcare is team-based and interdisciplinary. So working with the constellation of people who are a part of anybody's support system, whether it's the doctors, the nurses, the family members, the neighbors and friends, and so on, right? How do we think about that? Recognizing that people have non-medical needs. It's not all about treatments and medications and those kind of supports, but also people have broader aspirations. And this comes out of, I think, of the direct support professional field, making sure that we understand that. And that also people are part of complex and larger communities. And this is especially true for immigrants. Immigrants who show up on the job are largely navigating outside the job the complexities of an immigration system, right? And of a society that has become, especially in recent years, more hostile. And so how do we think about those outside needs? Some specific advice in terms of how do you support patients in their engagement with direct care workers? I mean, one is really having a clear understanding of what the direct care worker's role is in that relationship and what it is not asking a worker to do tasks that actually isn't within their purview and may actually be offensive, right? So being clear from the get-go about what is that scope of work that the worker that you're working with is charged with doing. Really understanding the challenges that workers bring to the job. This presentation was hopefully offered a number of detail on that, but knowing that workers come on the job with a variety of stressors and pressures. Third is being really explicit about your preferences for care or your client's care, and so that the worker knows kind of inside out what it is that the patient or the client needs, and that there are no misunderstandings about that, their needs, their preferences, and their aspirations. And then, of course, helping the patient and the client navigate the dynamics of the caregiving relationships. I mentioned the care team that is a big part of anybody's support system. Sometimes the work requires navigating those conversations, and how can rehab professionals and other healthcare practitioners support in that regard. Another way is, how do you support direct care workers in their engagement? One is to ensure that direct care workers are properly trained and to kind of get a sense of what that training looks like for the individual worker you're working with. Second, making sure that workers have a real understanding of what person-centered care or person-centered supports means, and that also, as necessary, that they're trained in kind of the cultural and linguistic competence needs, depending on the patient involved, right? One clear example is if the patient is LGBT, making sure that the worker, is not homophobic, for example, or transphobic, that they're able to understand how their biases might be playing out. And increasingly that they're skilled in relational care, that they understand proper communications, problem solving. So much of the work that workers do is emotional labor, and have they been trained and supported to deal with those emotional questions. Employers can, of course, help recognize these job and life barriers and develop systems to address that, and also create a worker-centered culture that really acknowledges not just the needs and aspirations of the consumers, but also what workers need. Finally, many healthcare practitioners play a role as policy advocates and industry advocates, and here there are a range of solutions that need adoption, from upskilling workers to make sure that they have the right skills from the moment that they begin their jobs, to creating paths and advanced roles that allow them to move up in their careers, and also be properly integrated as part of the care team. Building knowledge so we have better research and analysis on this sector. I mentioned a few areas where we need that level of support. Public education campaigns that raise awareness of all these issues that I mentioned, but with a broader audience. And of course, policy reforms that change the policy landscape for these workers. Everything from increasing compensation to building a stronger safety net like childcare and paid leave for these workers, strengthening training requirements, but also the quality of training programs and creating career advancement opportunities, really professionalizing this workforce and elevating their role within the sector and within healthcare and the economy in general. Improving data and investing in new workforce innovations like technology where it's appropriate, and of course more money for the whole long-term care system, and also specifically to workers, and money that goes directly to their paychecks, and addressing, of course, the ways in which systemic racism and sexism, among other inequalities, has shaped and continues to shape the jobs and lives of these workers is a major piece of that. I'm coming up on the end of my presentation. I just want to say that a few resources, a lot of this content and additional resources are available on our website, phinational.org. We also have a state-by-state workforce data center where you can look at some stats based on the state in which you're based. So hopefully that information will be helpful. In May, we released and launched the National Direct Care Workforce Resource Center, which is the country's premier online library of any publication that's been published on the direct care workforce. This is it's available through our website as well, and you can access any publication, not just PHI's information that's been published, although we're still growing it, so it doesn't necessarily reflect every single publication yet. And then this year we've been releasing a report called Caring for the Future, that bit by bit we're looking more closely at who these workers are, what the sector looks like, how we can improve the quality of these jobs through advanced roles, care integration, or just a broader quality job framework. And the full final report will come out in January of next year. But for now, you can access these resources. And of course, you can follow us on social media on these platforms at PHI National, or look us up by name, especially on LinkedIn. Thank you for listening. Thank you for joining this webinar, and I look forward to your questions and to the conversation that follows.
Thanks so much, Robert. That was really interesting. I think I hear an echo. Really interesting presentation, really compelling stuff. And I do see that we have a question from Jean Zaka, but I want to start the questioning with just kind of a broader, I guess comment, but also maybe a question about terminology. When we were planning this webinar, we saw your title and the reference to direct care workers. And some of us, well, all of us on the ACRM side thought, well, maybe that's not going to resonate with ACRM, audience members and ACRM members. And so we asked you then to change the title to home health workers. And now I see, of course, after hearing you give your presentation, that in fact that missed the mark as well. What I'm getting at though is that do we, given the numerous diverse stakeholders that are concerned about, and soon growing concern about direct care and home health workers, et cetera, do we need to work on our terminology across disciplines and across stakeholder groups? It's a general question, I know.
Yeah, it's a great question. It's a question I get a lot and PHI gets a lot. And to add a little bit of complexity to that question, these titles also differ by state and they differ by employer. So you can be working with, say, a home care agency in rural Minnesota, and these titles will be different. You'll hear terms like care partners, for example, right? I think it's important. Two points that I'd like to make there is that I do think it's important for us to understand kind of the different occupations because the occupations have different kind of requirements and standards attached to it, right? And they have different realities. So, as I mentioned earlier, a home health aide is required by federal law to undergo 75 hours of training, and in some states more than that. A personal care aide is not. And that's a great example in which, a difference in occupational title can emphasize an important point, which is we need to improve that training. Similar with looking at direct support professionals, I think the high-end attention on the needs of people with intellectual and developmental disabilities is an important piece. And it's important to point out that there isn't a federal occupation code for that, and that prevents our analysis. I think the bigger point, and we argue this at PHI, is that, moving away from titles, I think what we need to see more and more is standardization across this workforce and portability, right? We need to be able, if you're a home care worker, if you're a direct care worker in one state and you've undergone a specific amount of training, that training should be transferable across settings. If you take a job, say in another setting, like a nursing home, for example, and it should be transferable across states. Because that just strengthens the stability of the workforce, it professionalizes all the workers, and it raises the bar on everyone, right? And the problems with not having standardization really came to light during COVID-19, where you saw stories of doctors, for example, flying from other states that were not hit as hard to New York City, for example, and really stepping in and supporting people in hospitals and other settings. That would not have been possible with the direct care workforce because their training standards differ by state, and they just can't go from one state to the next, right? And that's a problem, right? So I think that moving forward, I hope that we can get more to a place where we're standardizing requirements and skill sets and competencies, and we're creating a system in which workers are able to move more easily within settings and across states. Yeah.
Super. Well, there's a lot to that, isn't there?
Yeah.
I see a question from Jane. It says, I think two questions really about the poor supervision causing turnover of direct care workers. And she asks, could you say more about what is meant by, when you refer to the, this cause and effect, what is meant by that? What did the direct care workers say in those studies? So that's question number one. And then as rehab providers are often training people with disabilities about how to hire and manage assistants. What role do you see us, rehab providers, in playing in improving quality of supervision when that supervision is provided by people with disabilities themselves?
Yeah, those are great questions. In terms of kind of digging deeper into turnover among direct care workers and getting a sense of specifically what do workers say. When workers have been surveyed, and that's part of the challenge in this sector, is that I don't believe we have enough kind of market research or research where we ask workers specifically about kind of what animates them about their roles, why would they leave, why would they stay. And that creates kind of it makes it difficult for us to know what that looks like. But I think when workers have been surveyed, as I mentioned earlier, the two top reasons that often come up are low wages and poor supervision, right? They say that it's simply not possible to make ends meet on $12 an hour or less, especially when you have family needs and healthcare needs and all of that. And oftentimes supervision, impedes them from really wanting to stay on the job. And actually, that's probably a bit true about any sector, right? Many people often leave their bosses; they don't leave their jobs, right? And so I think that that's something that gets really reinforced. What makes it a little bit different in the direct care sector is that we think that part of the reason that supervision isn't as strong as possible, one is that oftentimes supervisors come into these roles with very little preparation, with little coaching, little kind of executive level supports or management level supports that would make it easier for them to understand how to supervise a pretty complicated job that, as you can tell, has a number of complexities to it. The other piece is that scheduling is often one of the biggest challenges. How do you schedule workers? How do you spread out, a set number of workers across numerous cases that are often very different, some of which are very complex, within a given week and within those hours. And supervisors sometimes lack the technology to be able to do that efficiently, or may just rely on methods that just aren't great. And so workers will be frustrated that they're being assigned multiple cases within a day, not given enough time in between schedules, not being given enough support when they're on the jobs with questions, etc. And so I think all of those contribute to the turnover. And as I mentioned, in a time of a good economy, workers have more options. So, if you're dealing in a job where, you can work kind of better hours and earn more money in fast food or retail, and it's arguably less psychologically and physically strenuous, you might want to make that choice, right? And so it speaks to the importance of really transforming the quality of these jobs to prevent that turnover. The piece around supervision, like what is the advice for kind of supervising managers? We have a whole service line to help supervisors, and it's a big part of what PHI does. On the other side of our organization, I oversee our policy and research side. But what we do is we work closely with providers to understand kind of what does supervision look like in your setting? What do workflows look like? What are the expectations that are put on workers? How trained are supervisors, et cetera? And what kind of culture do you want to create that's both person-centered and worker-centered? And then based on that, we then develop a program that works closely with all those supervisors and trains them in the right way. And those interventions can be, I imagine, 6 months to a year, or maybe even longer, depending on what the goals are of the provider. But short of going into kind of all the nuts and bolts of that building supervision approach, I would say, if you're interested, we're happy to have a conversation with anyone on this call about what that would look like specifically. Yep.
Great, super. And we have another question from Jean Zanka, and it is related to the idea of growing knowledge about the direct care workforce. What data from the care recipient side, experiences and health outcomes of people with disabilities, would help support your efforts to advocate for the needs of direct care workers? So what can we learn from the care recipients to sort of advocate for the needs of the direct care workers?
Yeah, it's a great question. And as as I made the question about, it's the research on direct care worker experiences and needs and attitudes is really thin and needs development. I would say there's also similarly a gap in research about care recipients' thoughts and experiences on direct care workers. There are a number of topics that need more funding that I imagine people in the field would want to kind of study to get a better sense of what all those questions are. Two key topics that I think are relevant for that question. One is that it's difficult for us to get a sense in any state what unmet need looks like. In other words, if you want to look at kind of a rural Colorado and you want to get a sense, are there enough workers in this part of the state to meet the basic needs of care recipients, it's virtually impossible to arrive at that data. Part of the challenge is we don't have data on workers, but also we don't have comparable data on the other end that would give us a sense, okay, like in this part of the state, this is the type of care that's needed, this is the hours of care that's needed, these are how many people need those hours and that type of care, in a way that's truly kind of rich with data and in real time, so that at any point you can say, you know, look, we need more workers in this part of the state, specifically on dementia care, et cetera, right? So I would say the unmet need is an area that needs to really grow in all parts of the country. And I do think we need more, just generally more market research that asks consumers and care recipients about, you know, what are their needs, specifically from direct care workers, what are their experiences, maybe even looking at what are their biases about workers and their workforce, so that we can get a sense of where there's development there. And to the question that was posed before, what are supervision needs that consumers might need to help support these workers? I would say those are two initial areas that we need. Yep.
Super. I want to return to the, you know, you spent a fair bit of time talking about cultural and linguistic competence, and it seems really central, especially in, obviously, in this sort of endeavor, right? So the you know, engagements with clients are often, you know, are long duration, possibly full day, full shift, if you will, you know, and possibly without any sort of terminal date in sight, et cetera. And so it's, you know, it's up close and personal, and it involves a fair bit of, if you will, relationship building. And I'm wondering if on the, you know, what on the client side could be done to train clients to be sort of better at, you know, meeting their direct care workers, you know, somewhere in the middle and building a positive relationship.
Yeah, it's a great question. I think my first response is I think it's a mix of training and education. And on the education side, there are a number of organizations out there that are led by, you know, that are led by communities of color, immigrants, LGBT people, et cetera, right? Populations that need that cultural and linguistic competence. They've produced a wide range of resources, and becoming familiar with what those resources are. Those resources, by the way, will differ based on where you live in this country. So if you're in a part of the country where, you know, you have a high percentage of immigrants, let's say from Latin America, the cultural and linguistic competence is going to look different, in that you may see, you know, the need for more Spanish or Portuguese resources, or information that really speaks to kind of the diversity of Latino populations in this country. If you're in a part of the country where there's a big American Indian native population, you may need competence in that regard. I think training modules, you know, it's important if you're, I think first of all, it's important to find out who's doing the training. If you're working with an agency, or if there's a training, you know, module that you can purchase, say online. I can imagine that there are kind of a wide range of modules that some of them are at the highest of levels that really teach kind of cultural humility or kind of rethinking your implicit biases, those kinds of trainings that you can take as a consumer, as a professional, and you can become a little bit more versed on how do you support people who are more diverse. If it's part of a broader training program, one of the challenges that employers often have is that those training programs are already pretty long and include a wide range of topics. The best ones do. And so I think it's important to figure out where and how to integrate the cultural and linguistic competence piece and still create a training program that isn't too long and that's affordable and that makes sense for your population. But what we have learned is that it's become increasingly important, both because I think people deserve supports that are tailored to their cultures and their languages, et cetera, but also you want to prevent, you know, instances of discrimination. You want to prevent any kind of complexity in that regard, right? So I do think, you know, looking to see if there's an agency involved, what they're producing, or if there's an agency in the community or an online offering that we as individuals can take. I think it's important to sort of start first where, you know, in your local geographic community.
Super, thanks. And about COVID-19 in our current conjuncture here, right? can you comment on any initiatives that may be underway to train direct care workers and their clients, if you will, in safe practices while working together, if you will? And are there initiatives, and what can be done?
Yeah, absolutely. So there are probably a wide scattering of local initiatives, and you can probably get a sense, and many of the initiatives are probably happening from individual providers, and providers, I mean, agencies, institutions, universities, et cetera. You know, if you Google COVID-19 home care training in your city and state, you probably, something will come up, right? I mean, this is something that it was very clear that people needed to respond, and they developed as much as they could COVID-19 specific training. There is an organization in the field called Care Academy, and they have also a COVID-19 training that I believe anybody can take. And they're, a respectable organization that bases a lot of their analysis in the field. And I think it's fair to recommend them. They do, their training is pretty strong. At PHI, we're doing two things. We're working in 3 states to pilot both an advocacy initiative that helps us understand what's needed in a COVID-19 environment, whether it's training or policy supports or education on this. And we hopefully will have some good knowledge by the end of the year about that. And then our own workforce innovations department is also thinking about how do you either develop specific COVID-19 training or integrate it into existing trainings. Most of our training works closely with providers, so we don't offer the training kind of on an as-needed basis for individuals online. But if you're a provider or an employer and you're interested in kind of learning more or maybe even accessing some of that, we're happy to have that conversation. Yep.
Super, and we have a few minutes left. I want to return back to the care gap. I found those charts that you displayed really striking and worrisome. And so I have to ask, is it too late? As young people migrate to the cities, and then older folks who live in the countryside and rural communities, they find themselves without, potential care providers. Are they then, the speculative, I guess, this question, are they going to then also have to migrate to the city, and then is it too late, I guess?
Yeah, it's I don't know if it's too late. And I think what we see when we look at rural America and the direct care workforce is, I think what a lot of healthcare leaders see when they look into that area of the country. One is that they just see fewer health resources, and you hear quite a few stories about hospitals closing and healthcare offices closing, clinics, all of that. And fewer health resources per person, right? And that puts a lot of strain on people, and it puts people in danger to some degrees. With the home care, one of the challenges is that workers often have to travel long distances in between clients, and that makes it harder to assign multiple clients to a worker, and it incurs cost in terms of travel, gas, psychological cost, and physical cost as well. So I think I think some of the questions that we'll have to answer to really ensure direct care support in rural America. I mean, one is there a role here to maximize technology, recognizing that most direct care needs to be delivered in person, and that home, technology is probably never, at least in the foreseeable future, going to supplement a worker, right? So it's never going to replace a worker. So how can we think about technology in terms of maybe maximizing scheduling or screening people before a worker arrives? I mean, all the ways in which it can make the job easier without replacing the worker, I think is going to be a big question for rural America. And increasingly what we're seeing, what works in rural America are community partnerships and the role of civic organizations, churches, small colleges, all those supports that people in rural America will say, this is my community, right? How can we sort of tap into all of those community resources to also support the delivery of care? But it is concerning as more family members leave leave towns and rural parts of their states for other cities. It's leaving their family members without supports, and people with disabilities at all ages need that support. And so we need to think about what does kind of the future of rural direct care look like? especially post-COVID-19.
Excellent. Well, Robert Espinoza, thanks so much for sharing your experiences and your expertise. Very stimulating discussion. Thanks to everybody for attending this webinar. The recording of this webinar will be available in the next 24 to 48 hours on the ACRM website. Please do recommend this webinar and the webinar series to your colleagues. And this concludes our episode for today. Be safe and stay healthy, everyone. We hope you have the chance to join us again for the next pandemic webinar. Thanks so much. Bye.